Hi everyone, my name's Linda Gage. I'm a contact mum, but also a internationally board certified lactation consultant. Originally from New Zealand, and we have 4 babies. My background is also in nursing. I spent a few years working in the neonatal unit, but since all my babies have grown up and now having babies of their own, the last 10 years or so, I have been training and working as a lactation consultant in California, which is where we're currently living. So what we're going to talk about today is what is a tongue tie, and help you identify and support just your families who might be either wondering if their baby has a tongue tie or going through some information and treatment for it. So I want to give you an overview and look at the options. I do want to acknowledge that depending on where you live or where the mamas live that you are working with, the assessment and treatment options that they might have vary widely. And so some of the things that I suggest may or may not be as accessible for your families as what they are in some areas. This can vary from city to city as well as country to country. But also there might be some things that are a choice of theirs that they're like, no, we don't want to do that. We would rather do this, or we want to, whatever. So they may definitely try and work with it in different ways. Tongue ties are not new. They've been recorded for, hundreds and hundreds and hundreds of years, and certainly even into ancient times. And this is something that is the fascia part of the body that is a connective tissue that runs all the way from the head and from the tip under the tongue there, all the way down to their feet. So if there's tightness in that, it can sometimes restrict restrict movement and restrict function. And that's the tricky piece about tongue ties and lip ties and cheek ties, because what they can do is make feeding, which is vital for babies to be able to grow, into something that's really quite tricky. So this is and it really, as we go through this talk, we're going to talk about the symptoms from the infant's point of view, the mama's point of view. We're going to talk about some of the different ways to get it assessed, and the different treatment options, just so that you kind of have a really good awareness of what that can look like, and maybe are able to encourage your parents. So let's start with what it can look like from the baby's point of view. And what I want to acknowledge is that they vary widely, and we're going to look at it a little bit later on. But just because you can see something there, just like if you think about rubber bands or elastic bands, depending on where you are living, you can get thick short ones, you can get thin short ones, you can get thin ones that are super elastic. So just looking at it is not the only piece of the puzzle, but we'll talk about that more later. So from the baby's point of view, these are some of the things that the parents may be saying, hey, my baby's really having difficulty latching. Breastfeeding is really tricky. They're very noisy. They come on and off the breast all the time. I can hear a clicking sound. Their poops might be explosive. Some babies can't feed enough, and so they have a really slow weight gain. Other babies, when they're breastfeeding, they're feeding so frequently because they're not able to get really empty the breast well, that they're getting lots of that higher carb milk that tends to be towards the beginning of a feeding, and so their poops are really explosive and you get this fast weight gain. And so the gassy kind of reflux symptoms can definitely be a part of it, and it's not an acid reflux. it's actually more of a air reflux. So we call it aphasia, where they really are sucking in so much extra air because of the clicking and the popping on and off of the breast or the bottle. That can make things quite tricky. Blisters on the lips, especially the top lips. I mean, in the first few days as baby gets used to nursing, there can definitely be a little bit of kind of lip blisters there. But if they're getting worse and they're staying there and the lip is really tucking under a lot, then that can be something that shows that the feeding is not ideal. A white coating on the tongue is sometimes mistaken for thrush, but this is because the function of the tongue, which should be a lovely full peristaltic wave motion as it sucks in, it lifts up to the palate, sucks in the milk, and then moves it back. If part of the tongue is tethered and can't move up properly, then you can have the front part working okay, but the back part or the mid part is not washing that milk back properly, and so it keeps a little bit of milk just stays on the tongue, and you get that what we call a milk tongue. They can fall asleep very quickly at the breast, and this is usually because they're frustrated and they're not able to get milk, so they just stop and have a nap. You get lots of suck, 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 but few of the lovely big wide open kind of suck swallow motion that we want to see. They can often seem to be never satisfied, or they just breastfeed all day long and have to have quite frequent feeds. And this is where you really think about, as it talks about in the courses and the books, if a healthy baby should be able to take a full and effective feeding, it might mean that some of their feeds are a little shorter than others, but overall in the whole 24-hour scheme of things, it's going to be they're going to be able to get some really good full effective feeds where they drain you properly, they feed a whole bottle without really struggling or leaking everywhere, and that it should be able to be done by most healthy babies. So if not, and if you're seeing some of these things and they really are looking to feed so frequently, then this could be part of the picture. So let's talk about it from the mama's point of view. Painful breastfeeding and nipple damage can definitely be part of the picture. That can look different. It can be just the initial latch, and because baby can't keep a good latch for long, they might pull back to quite a shallow latch, and so then you get the nipple pain. If they are having to do a lot of what we call compensations to stay on the breast, because they can't just stay on and actually use their muscles in the normal way, but they have to use their extra cheek muscles, they have to really purse their lips to stay on, then sometimes that can provide kind of a more chompy motion, which can almost send like a nerve pain into your breast. So sometimes that pain can be just on the nipple. Sometimes it can be further down into the breast. You might get misshapen or damaged nipples after a feeding. Certainly a flattening, a creased, or a more kind of lipstick shape at the tip are very common. And one of the main kind of first issues that I try and encourage women to do is to make sure that they're actually nursing or breastfeeding in a position that has baby more on top of them. So if, for example, a baby is trying to nurse and they really do have some restrictions, or it's just the first week or so and all of a sudden they're having to do all this work and they're finding it hard, they're falling asleep. If your baby is coming from underneath to hold on and suck, swallow, and breathe all at the same time, it's much easier for them to slip off. If they are coming on top of you, so if you're doing more of a laid back position, or if you're doing cradle and you lean back so that baby is more on top of you, then you're using gravity. Their jaw and their mouth will be a lot more relaxed overall, and they'll be able to maintain that deeper latch for longer. So sometimes with some tongue ties, that can help a lot. In general, just for any newborn baby, it's a really good thing to be doing. But if they're pulling back and you're seeing that compensation of them not being able to maintain a nice wide deep latch because the tongue just can't move all the way up to compress and then vacuum with up to the palate, that can be a tricky thing. So if you're not getting good emptying, you can definitely be more susceptible to frequent clog ducts and engorgement, blebs, which is kind of like a pimple that blocks the areas on the nipple where the milk's coming out, or mastitis. You can definitely get oversupply from super frequent feedings, or a low milk supply because baby is just not able to give you enough stimulation to build your milk supply. And all of this can definitely lead to exhaustion and early weaning. And if you have a parent who's had to switch and do a bit of breast and a bit of bottle, and they're pumping and bottle feeding and trying to nurse still, definitely it can be really, really tricky. So let's look at how these are assessed. We have 3 basic types. There's a few different places in the mouth. There's the upper lip. So just up here, you'll see there'll be a frenum there. And usually if there's a frenum and it's got good movement, then it's totally fine. If it's super tight, then that can definitely affect feeding. You've got the one under the tongue, which is the typical what we call the lingual frenum. So that's under the tongue, and where it's attached can be anywhere from the tip to here to here. It might just be a posterior one. The front is able to do lots of wiggling and moving, but the back end is not pushing it back properly, and baby's getting tired and doing some of those compensation we talked about. You can also have cheek ties. So you can have them here, and you can have a lower lip one, which would be to the gum from the lower one. So what does it look like? It can really vary a lot. Some are super obvious, and some, as I said, are further back. Some might be obvious, but they're not tight. They've got good function, and so then we don't want to just go in and snip willy-nilly. What we want to assess is A, what it looks like, but B, what does it do? So we talk about extension, which is coming out. And if the baby can't even get the tongue out to the gum line or past the gum line, then there's definitely an issue. Lateralization is the tongue being able to move side to side. Elevation is resting up on the palate. One of the things that we find with tongue ties is the natural place that God designed tongues to rest is up on the palate. For those that have a short frenum or a tight frenum and it can't, then what that means is that you tend to get the tongue is not doing its flattening out and widening work on the palate, and so you can get a super narrow palate and a high palate. And if you think about, say, this is the palate up here and this is the tongue, if the tongue is tethered and you've got a high palate, it's super hard to be able to actually compress the breast or the bottle to be able to keep working because it can only do a bit. And if they've got a little narrow, shallow latch, then it's even harder. They really can't get it up. And so again, that's why going on top is much better. And then we want to look at what the tongue can do. So during a feeding, we want to watch, are there dimples? Are the lips tucking under? Is the baby got extra tightness here? Is it a really chompy suck? Is the baby not able to get a lovely wide latch? Is it just kind of more like this with the chin kind of tucked up? And does baby have a recessed chin, which can sometimes show that it's being kind of pulled back? So you definitely want to ask for a functional assessment with a lactation consultant who has extra training in ties. Some of the hospital trained nurses we find and lactation consultants don't have that extra training, and some are even told that they're not supposed to suggest that somebody could have a tie. So definitely be careful about that. Okay, so this is one of the assessment tools. I'm going to show you a couple of them. This is one that really shows what the variety of things can look like. And as I said before, these are the different areas that we're doing, that we're looking at in terms of what the tongue can do and what it looks like and what the restriction, how the restriction is changing it. So this is called the tabby tongue assessment. And you'll notice that by the look of the pull of the tension of that fascia, the frenum that is there, it can create tension and change the look and the function of the tongue. One of the ones that I find super, super helpful is this one called the FLIP assessment tool, and it looks at flow, latch, injury, and post-feeding behavior. So what we're looking at is a really comprehensive, from the point of view of the parent, showing what the baby's behavior is in these different areas. This tool was developed just a couple of years ago by a pediatrician who's done a lot of work in this area. And this can be super helpful in seeing progress. Like if you do it and you score it before they have treatment and then after, or before you put some different maybe position changes or techniques into place, and then you see a huge improvement, that can help you make the decision whether or not you might need a frenectomy. So let's talk about the different treatment options. First of all, not everybody has to have it snipped. So there's definitely feeding support and body work can be super, super helpful. Because the frenum is part of the fascia, it really responds, it's part of that tension is to do with like the nervous system. When you relax the nervous system, things like massage, warmth, and pediatric chiropractic, cranial sacral therapy, which is the CST, infant massage, all, and some exercises and things can make a big difference. When a baby first is born, they've been cooped up in utero, in the womb. It's been getting more and more uncomfortable. And some babies who need some extra help to get out, maybe they were around the wrong way and came out that way, or breech, or just the normal good position, they still have to squeeze through that birth canal, and sometimes they get pulled, certainly if there's a vacuum-assisted birth, or if they are C-section, then they're going to be pulled to bring out. That's just going to make things, tight and sore. And so really initially, the first few weeks, it's super important to let baby stretch out. That's why tummy time on your chest and some contact naps on your chest, skin-to-skin time between feeds occasionally is super, super helpful. You want to encourage baby to go both sides. So if your baby usually just either lies in their bed to sleep with their head turned this way, or when they're on you, they always turn their head one way. When they kind of stir mid-nap and do that kind of, halfway through the sleep cycle, they're going to be stirring. That's a great time to encourage them to have their head go the other way. You will find some babies that really, their shoulders are up around their ears when they're feeding, and all of that kind of held tension makes things difficult. Sometimes just having exercises, positional support, and some body work can fix the whole thing. Just because it looks like a tie, or there might be difficulty, or you're seeing some of those symptoms that we talked about earlier, doesn't necessarily mean that it is a tie. So always go for the feeding support and the body work and the movement and tummy time and all of those kind of things, letting baby stretch out first before you leap to any conclusions. And even if baby does have a severe tie, then you will get much better healing if you're doing this kind of work alongside it. So the procedure that a baby would have for a tongue tie, if it is diagnosed, is called a frenectomy or a frenotomy. So the frenum is either opened or cut, and so that's the otomy or the ectomy part of it. It's releasing the fascia, and the provider is going to use scissors, a CO2 laser, or a water laser. But I don't. Some people still use diode lasers. They definitely do a little more damage, so definitely would avoid that. CO2 lasers and water lasers, definitely a CO2 laser, super fine, super precise. You can get a really, really good outcome with those. If you have somebody using scissors, that can be okay if they're super experienced. And but a lot of providers now are going for the CO2 lasers. Some are using the water laser. A water laser just uses a slightly lower temperature, but some people think that you get a better outcome with the CO2 laser. So who is this going to be with? Certainly you want to be working alongside a lactation consultant or some bodywork providers, like I mentioned earlier. But the person who's actually going to do the procedure is usually going to either be a pediatric dentist, an ENT with experience in this area. Some midwives or pediatricians or lactation consultants will also do it. They will probably do a scissor version and not necessarily a laser version. Some pediatricians might, I'm not sure. Really depends where in the world you are. When should you get it done? In general, the earlier the better. But you definitely want to be doing some initial relaxation and just preparing the mouth and preparing the baby for the procedure. So we want to be aware that around 4 months, 4 to 5 months, that suck reflex that helps our babies to feed so well in the early days is integrating and becoming voluntary. So when you have it being more voluntary and the baby has been used to sucking in a certain way because of the restriction for the weeks and months that since birth, but also because it actually developed in utero in the beginning of the second trimester is when the fascia is all kind of separating out, and that is a long time. And so a couple of things happen with that. One is it can make it harder for the baby to relearn good sucking patterns and relearn and how to use their newfound freedom. And so in general, the earlier the better. And the first 3 months is ideal if you're going to do it. But also if it is done later, like over 6 months, 6 to 12 months, like baby is just a lot older and a lot, they know their mind a little bit more. They can be more difficult to manage in some ways, or they might have to have a general anesthetic or some form of anesthetic. So certainly when frenectomy or frenotomy is done, often they will use a little bit of local anesthetic, especially ENTs and if you're using the laser. But if it's not done earlier and it's more like 12-month-old or a toddler, then they would probably do it under a light general anesthetic. So really important piece of it is for the treatment is the aftercare. There's 2 sides to the recovery. One is the tension aspect of it, and the other is the wound healing. So when we're talking about the tension, when that fascia gets released, that can actually, you can see babies' toes uncurl. Like you might have a baby that's got super tense like feet that are always curled under. When you release that fascial tension, it definitely helps the rest of the body. So often I'll see babies who arch or who are super tense in their torso. These are the babies who might maybe roll over at like 3, 4, 5 weeks of age, and we think that's amazing, but it's just the tension. It's not them actually actively rolling over themselves. So that local in the jaw, in the mouth, Still, you want to definitely be working with somebody who can help walk you through how to support the return of oral function, and as well as addressing the body tension, because as that body tension gets addressed, that's going to relax everything, and then the feeding's going to get better. They're going to be happier in a position for breastfeeding or for bottle feeding. You won't see them like arching so much to keep their airway in a good position so that they can do the suck, swallow, breathe. So that piece of it is super important. Then you've got wound healing. If you do nothing and baby still is doing what their tongue used to, you will get usually reattachment. So stretches and movement and a nice deep latch where baby is working really hard and well with their bottle or with the breast is really important to help with the reattachment side of things. If you're using a bottle, you definitely want to be using one that's wider based. So if you think about what it looks like inside the mouth of a baby, if a baby uses something like this, you can see they might initially get a good latch, but they're going to just rest and just go chomp, 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 chomp. So you want something that's wider. We talk about the triangle test. So there's a lot that have a nice full, and baby's mouth is going to stay all around here, and they're going to get better, wider function. Same with the breast. You want a full, deep latch, so a good mouth of boob in their mouth. So those stretches and things are going to be taught to you by whoever the provider is. And if they don't give any, then encourage the family to see a lactation consultant who will help them with that. Then habilitation or rehabilitation is, and in this case we call it habilitation because they weren't doing good oral function before, so they're actually learning from the beginning. So this can include things like suck training, oral play, using good teether toys that are going to promote good oral function, breastfeeding positions and latch, paced bottle feeding with a wide base, nice full one, as I said, and tummy time. Tummy time is great. Babies should be doing tummy time every time they're awake in some form. They should have a bit either on you or they should have some on the floor, even if it's just a diaper change and you've changed their diaper and you're going to just roll them onto their side, roll them onto their front and go down and talk to them from either side for a couple of minutes. That is bonus tummy time. Carrying them around on your face down on your arm when you're walking around the house, that is bonus tummy time. All these things can really help with a baby who's been tense and has had issues with oral ties. But the full healing does take time, and depending on how much tension there is overall and what kind of happened from the beginning, sometimes it can take a month or more to really get good function going. Okay, so these are some references that I have found really good. This is a variety of dental, ENT perspective, lactation consultant perspective, some of these who work together and have done a lot of research in the area. So definitely some good ones to look at if you want to look into that a little bit more. That hopefully will be super helpful. So I know we're not having a Q&A today with this, but you are very welcome to contact me if you have a, let's just put that somewhere else. Hang on. There we go. If you have a family that you know that is struggling with it, you're welcome to get in contact with me. I'm happy to support you. I also, in my private practice, take paid clients. I'm happy to do initial consultation for free in terms of just checking out where things are at and if a full consultation is needed. The older photo there is me with my oldest son, and then the next photo, he's asleep in the corner while I'm snuggling his daughter. so which is just lovely. But definitely have, as you look at feeding challenges, if things are not going well to expectations, look for what the reason is behind and encourage your families. Some used to just go straight to the bottle, and unfortunately, although baby might gain weight and get fed, it doesn't help with their oral function. And in the long run, they can definitely have issues with either speech, transitioning to solids, the airway, orthodontic treatment from that, the high palate can get more complicated. So it's definitely good to get it assessed when they're little. And you're welcome to contact me anytime. I hope this has been super helpful for you. And I look forward to just having more connection with you as you support families. Thanks a lot.